still.
No, yeah, totally get it. Totally get it. Okay, the recording is started. Welcome, everybody. It is Tuesday, June 20th, and we are here for another Florida EMS webinar, which is part of the Florida chapter of the NAMSP. And today we have an amazing guest who was very kind to quickly respond on Twitter that he'll come on and talk about the paper that he just recently published with his team. So Dr. Mike Berkenbush is from New Jersey with the Atlantic Health System. He's one of the associate medical directors there, which is a hospital-based EMS system, and he'll kind of describe to us Florida folk what that means, what that looks like. Great paper, which I'm really looking forward to the discussion on this. So let me pass it over to you, Dr. Berkenbush. Thank you so much for joining us, and take it away.
Great. Thank you so much, Dr. Antobi. Appreciate the opportunity again. So basically, to talk about our airway management program, and really this has been a kind of a process over years, even spanning before my time at Atlantic Health, which I'll kind of talk about kind of the history of how we got to where we are, then the genesis and so forth. I guess the brief version of who I am, I started out as a paramedic, which I still work, still practice in the field as a medic once a month, just keeping my street cred there. Work in 2 ERs, academic and community setting, and associate medical director with Atlantic Health, and then also help out with the EMS fellowship program that we have. And then my side gig, I work as a flight doc out in UW in Wisconsin. So that's my background. So paper we published in General Reports is entitled High Performance Prehospital Airway Management. And basically we talk about some of the general components of our airway management, I guess, program that we have at our ambulance company. That's we think has really overall kind of improved our airway management success over time. And we'll show a little bit of the history. The main focus of the study is kind of looking back at the last 2 years, 2010 to 2021. But there's a lot that came before to kind of get us to that point. I'll kind of go through that a little bit. But I think kind of our highest level success just shown in those 2 years is what we're aiming to publish. Especially kind of this comes with interesting timing. I mean, with NAMSP, the recent airway position statements, and I think some of these components probably will look familiar as and anyone who's kind of reviewed those position statements. I imagine most of the a lot of I think some of the things we're doing are kind of fairly congruent, which what you may find in those position statements. Again, we're focused on 20 to 21. Some of the background on this, just kind of give you a little history. Really kind of our initial genesis. Unfortunately, Dr. Alritter mentioned there was on vacation, so I was going to try to come on here, but he was really he's been the medical director since we moved to video laryngoscopy in 2010, which I think we're one of the earlier doing it at the time anyway. But he kind of a form of analysis trying to determine what can we do to improve airway management success. At that time, they were probably just kind of in the broker realm of airway management success. Using direct laryngoscopy has really been a huge focus ever since he started being medical director just prior to 2010, I believe. And he decided at that point using hyperangulated video laryngoscopy was going to be his technical choice, and he kind of evaluate all the current devices at that time. And that's kind of where we ended up going. Follows less traumatic in the airway and best airway visualization success rates. So ended up starting with Glidescope. And kind of the results of this study is all the culmination of his efforts over time, along with our clinical team, really focusing on. We're going to want to make a big focus over really the last 13 years, ever since they started out with using video laryngoscopy and some of the other components that have come along the way, which we'll talk about. Kind of our education around it has changed over time. Obviously, using SALAD, as you'll see, and then a little bit on skills proficiency as well, making sure we're kind of getting aggregate exposure to the skill and maintaining that. So really, in the end, this is more. I feel like it's more like a quality improvement kind of discussion of kind of steps that we took over time to get where we are. So this is just really brief about New Jersey, but I mean, like all EMS systems, unique as one might say. So we're Atlantic Health. We're kind of the orange. Let's see if my mouse there. Orange here, and then this kind of usual orange district spanning a couple of counties up north. This is kind of our primary area. Recently, Atlantic Health gained hospital center state, so we cover an area kind of in the central part of the state as well. It's so you can probably see pieces of different counties. It's kind of a disjointed system based on certificate of need that the hospitals were granted, I believe, like 30, 40 years ago. That just kind of ingrained. So each hospital has the area that they cover. So this is all hospital-based sections of the state, kind of throughout different counties. Generally, it surrounds your main hospital and flagship hospital being Morristown. So we cover kind of the area around there, some of the outlying ones as well. So Lansing Health has like 6 hospitals now. It's a dual paramedic system. We're all kind of in, I guess, if you fly car system. So BLS it's really completely 2-tiered. BLS almost all separate. Now we do have our own BLS division where we're covering a lot of towns during the day, and some 24/7. But very much, at least for this map, this is kind of the ALS map. We're basically 100% coverage of ALS throughout the state with all the different programs. It's kind of where we fall in there.
Mike, just as a quick question, just so reference for us.
Sure.
You guys are in a fly car. You have a BLS response for, that's not connected to your system, and then they get there and they're, depending on if it's a Delta Echo, let's say, are you automatically dispatched out as well at the same time? And then what is your typical drive time to get to the scene?
That's a great.
Yeah,
that's a great question. So yes, it's almost all the towns were auto dispatched, and we have kind of state guide cars. Most people use, like as you mentioned, kind of the Charlie Delta Pro QA system. So all auto dispatched. We actually have our own center just focus on our medics, so all the calls will go directly to our dispatch center that we dispatch out from ours. And then the drive times, in certain, say, from 10 minutes to a half hour is probably the average range. Probably max we're going half hour, 40 minutes at the max at the district. But yeah.
How many total paramedics does the Atlantic Health employ?
I believe we're at 170 paramedic level practitioners. That includes like medics and SC2 nurses. Our critical care nurses are, the way New Jersey works, we don't really have paramedics doing ALS transports. We have critical care nurses who do transports, but they all occasionally work in the field and paired with our paramedics. Okay,
got it. Thank you.
Yeah. So I think roughly, so we have like 10, well now I think 12 paramedic troops, if you will, kind of covering this area. 14,000 ALS contacts per year, roughly. So actually patients that we contact, there's a lot of cancels with our BLS tiered system. There's a lot of canceled off 14,000 patients that we see. And I think the municipalities is over 100, and we cover over 1 million in population. With all these zip codes, it was a little hard to get that exact number. So this is kind of just a little bit of the background. RSI was introduced in New Jersey in 2007. Like I mentioned briefly before, we started doing video laryngoscopy in 2010 using the Glidescope Ranger device. And then kind of throughout the years, kind of focused on our efforts to figure out where our first pass failures were and things we could do to improve. So 2018, we started using Duchenne suction catheters, focused on the saddle technique, and that with the use of a kind of home-built mannequin to practice on and gain proficiency with. And then in 2019, with the update from the Glidescope, we changed to the Glidescope Go. I guess I should add one of the initial policy changes, and you can imagine some of this is not easy to do, especially back in 2010. That was, I think, right before I became a medic. Everyone, some professors are very using direct laryngoscopy. There was a lot of resistance and hesitation to the initial change, and it was made a policy that video laryngoscopy would be the exclusive device in our system, which, Dr. Ritter, if he was here, would say there's getting buy-in from staff was a huge component of this kind of early on to kind of get people on board with what we're doing and showing that we're really going to make things better over time. And now the fruits of all that are shown kind of years later over time, but you can imagine this was not a politically, at the time, was a rough issue. So and this is again going back. So I've looked at this data now. I've been kind of analyzing for multiple years, even back to when I was a resident as well and started as a paramedic with them. So just interesting. This is just kind of interesting side note, just to see what happened when we first introduced video laryngoscopy. Things did not go as well as one might hope right off the bat. So this is just comparing direct versus video. There's still people, even though we said like you use video, there are people who are just like, I've always done it this way, I'm good at doing this way. And actually, we're doing this way, and the numbers show that. And so we were able to compare a little bit to the people who really kind of were resistant. And interestingly, the video after we introduced video laryngoscopy 2010, looking at 2011, 2012, our rates really did not get any better. I mean, we're still looking, right, 75% rates just using video, right, starting, and that's really where we were before. So this is where we kind of refocused our education. Again, Dr. Ritter was there, kind of really had some meetings with the staff. This is really going to do better doing this and really focusing on education. This technique is, and I think there's some, I may have mentioned in the paper, there is some data, I think even from anesthesia, changing when someone's kind of muscle memory and motor skill is set on doing direct laryngoscopy, video to them, there is a learning curve there, and a motor set. It's just different, especially hyperangulated, of course, in this case. So we kind of really, there's a lot of focus on more the getting, I guess, too into the weeds, but more on looking at just basic things like, so not only kind of separating the airway out into different parts, right? Visualization of the glottic opening, separating out passages of the tube, so not going too deep with the laryngoscopes that you're impeding your own efforts, different things like that. We talk, and then later on, of course, we'll talk more about salve and other issues that we came across. So it's just kind of interesting back in time. Things really took time to get better, and this is the graph that goes over that. So again, RSI in 2007, last year in 2010, kind of really seemed almost stagnant for a few years there as we increased our education. Then we're focusing on what were the issues. So some of the issues were contaminated airways, running all over the place. Something would get on your screen, you couldn't see, you backed up, you end up switching or going back to direct or something like that. So that was one issue. So home on South and Eucanto, I think, want to address that. Talk again briefly later. Sometimes we had equipment issues. So we end up actually now, so each unit is 2 paramedics. We have 2 complete identical set of airway bags. So we actually have a backup Glidescope for every single call. So if you have an airway issue, you have a backup Glidescope. We had some sort of issue initially, but had no other recourse but to go back to the old direct. So just kind of to give it a rough idea, so focusing now on the last 2 years of data that I had, 2020 to 2021, did roughly almost 1,000 intubations over 2 years. Large majority of that in cardiac arrest, 68%, 30% in RSI, 30% are RSI. Then pretty much any patient not cardiac arrest, we really were preferring that RSI be used. And that, of course, with optimization, if there was hemodynamic instability, kind of one other more recent thing that we're really trying to focus on, using dose epi, leofeds, you kind of get a sense we're using that fairly commonly, focusing on shock index, using half dose of ketamine for 1 per kilo if the patients have an elevated shock index to try to hypotension. Arrest-wise, I know obviously everyone's probably aware of the pragmatic trial. Given our success, we're sure that data was generalizable to us. So we have continued using intubation in cardiac arrest. Has some controversy. And unfortunately, we aren't part of CARES yet. Hopefully, New Jersey is on board with that and working on details. I can't really compare our cardiac arrest data, which would be interesting to know if down the line there are actually any changes along that. But unfortunately, I don't have that info as of yet. And generally for RSI, so you can see some obviously complications here. And then generally we're using ketamine, 6-1 being our primary agents. This is just kind of a table showing really graph by year. So just getting a sense of what we're using. So generally, now at this point, again, this is taking change over time. Almost 100% use of the video laryngoscopes for intubation. Just a couple rare episodes of direct laryngoscopy. Although, and iGel only pretty rare, since given our high success rates, we really favor doing intubation again during cardiac arrest. Some of these may specific airway conditions. I don't remember all the details on each one. But generally, so our first pass success rates kind of look at the overall here, roughly 93% for first pass success with a total intubation success of 98%. And I guess if you include success, including you putting in using an airway, there's kind of only a few cases that fall out that patients that didn't get advanced airways, and there's like 5 cases of those. Either an air crew arrived and took over, or the patient arrived in the ER and ended up going into the ER. Generally, the outcome there. Gel use was our backup. There's a, you can kind of see there, 18 or so. Even though we say failed intubation, I'm not sure that it really classifies a failed airway. So I would still say airway management, advanced airway management success for those patients, and then just breaking the RSI patients, which are congruent with the rest of the data there. So going into again a little bit more of the details how we got there, we kind of said the five components: education, using RSI, video laryngoscopy, skills proficiency. So initial education, obviously it took a greater form when everything was initially rolled out. But even for, so any paramedic entering the system, we spent about 8 hours on airway management, for that didactic, 4 hands-on, using SALAD technique, using airway SALAD airway mannequin. Any new paramedic or mobile intensive care nurse that's starting prior to 10 intubations prior, includes IGL adjustments. We review a lot of the kind of common errors with video laryngoscopy, kind of not focus, what we talked about before, glottic visualization, attached to the tube, using the rigid stylet, kind of getting the down the hall view, not getting too close, maintain the view until the stylet is out, obviously, then of course confirmation techniques. We do an annual psychomotor competency system session for all the medics as well. So kind of first, in one sense, doing just the skill itself, and then and that includes doing pediatric, and then putting everything together in a sim scenario. And most of the time we end up doing an RSI scenario on a regular basis, or annual basis. And then, like I said, 2011, we did a much more extensive training when this was all first getting educated to. We use for RSI, we use an app that one of our supervisors basically designed off of Microsoft Power Apps. So kind of going through preparation techniques, and again, like we mentioned before, using our dosing, you input the vitals, do shock index dosing as needed for ketamine, put in it selects the patient, kind of goes through some of the things to assess for difficult airway, reversible causes. Our system will call medical command for these. Optimizing the patient, which I think is also going to be key, because that goes into our success, right? Using non-rebreather nasal cannula, targeting SpO2s higher than 90% prior to starting, optimizing hemodynamics, whether it be push SFB or starting leafed infusion prior to, and then positioning, and then kind of doing a timeout before we go, and have both medics on board before we start. And just generally, we precisely call. We feel like there's less breakthrough awareness, make sure we're sedating patients appropriately afterwards. For SALAD airway mannequin, like we said before, most common reasons for first pass failure were air excretion, or blood in oropharynx. So we started doing the SALAD technique, do cancers in 2018, and this is kind of our airway mannequin that we have. It's kind of the blue windshield wiper fluid solution here. But kind of goes always teaching suction first for all patients, and left park technique as needed to help prevent issues with airway contamination. I think having the airway mannequin was really a great way to improve confidence and competence using the suction first technique and the left park maneuver, which has definitely helped. So like we said, generally we introduced laryngoscopy 10 years from the start of the study. Initially, there was a little change, but equipment failure was one initial issue when we first started. So having the second one definitely had kind of weigh that issue. So we always have a backup. The batteries are charged. You always have an extra set if needed. The only issue I think currently, every once in a while, we have a slight HDMI connection issue, which holding the Glidescope can prevent. So that's one thing that we're working on addressing. But otherwise, currently the Glidescope Go, I think the evidences of that are really minimal. Skills proficiency, I think some of this goes to our kind of our this two-tiered dual system, I feel like we got a generally fairly high exposure rate to critical care skills for our paramedics. For full-time medics, just defined it as an hour a year. The annual attempt rates were 5.8 intubations attempted per year. I guess just because it's a dual medic system, that if they're 5.8 themselves are involved in roughly 11 or 12 attempts a year with their partner. And for part-time medics, the rates are obviously quite a bit lower. This doesn't account for second jobs, of course, which most medics have, so that their actual annual rates are actually a little bit higher. But these success rates did not really change between our part-timers or full-time medics. For first pass success were pretty close. Per attempt success was fairly similar. And included in the part-time realm is the SCTU nurses who work as mobile intensive care nurses with our paramedics. So they have less exposure, so I consider them in the part-time category, but you can see the rates are still fairly similar. Couple last discussion points, now we're getting close to time here. So again, we continue to use intubation and cardiac arrest as we felt that the data there was generalizable to our system. I mean, I think the airway intubation success rates were somewhere near the 50% realm for the paramedic trial. COVID-19 was included during our range of dates starting in 2020. And we actually felt initially rates improved during COVID as people were kind of slowing down more time with airway, doing airway management. Number of attempts, just one question people may have, we're currently capped at 3 attempts between our 2 providers. That's kind of what we've set as our maximum, so not going more than that. This is based on respiratory chart review. We don't, unfortunately, as of yet, have the recordings of the intubations via Glidescopes to review and assess. I mean, that's something we're definitely hoping to get to. We said we use IELTS as backup. So kind of in summary, overall success rates were average of 98%, with a small percentage of the intubations properly managed with supraglottic tracer bringers. Overall airway management success near 100%. So hopefully some of the things we learned over time can help minimize the risks as an important skill, improve patient outcomes over time. So I think that's pretty much all I have. I guess the sidebar note is that we do, that doesn't really focus too much on this, but we use our ventilators for all intubated patients as well. Hopefully we'll be public more on that. Thank you very much.
Awesome. And I know Marv's about to come in here, but I want to just make a couple comments. So I'm looking at the graph, that slide that you sent. I think it was slide number 7. If you can you track back to that one, Mike, real quick? Because I'm curious that in the years 12, 13, 14, 15, 16, you were flat, and then suddenly in 17 and then 18, from 17 on, you started making the jump. What do you think it was? Because you hadn't had the Glidescope Go yet, you didn't have the salad yet.
True.
So what do you think it was? Was it just and then there was a point you said where you didn't permit directs. Can you kind of help us figure out, like, what was that differentiator right there that made the difference?
Yeah, that's a great question. And unfortunately, I wish Ritter were here to know exactly the timing, because actually the policy where we really weren't permitting it was really started right off the bat, I think 2011. So even having the policy didn't really change anything. One thing I did find, and there's evidence to show this in one of the studies we cite, that the time or the use of the success shown with laryngoscopy really improves over time as people are more comfortable. So I don't know if that's a factor of time, people being more comfortable with the skill over time, because I'm not sure that there was any direct intervention in that year that made the difference. I'm not sure if it's a culmination of efforts. Right. At this time, after 6 years of doing it, any medics were more fast, more older experienced measures who initially were hesitant have now been bought over and comfortable with the skill, and just that's a combination of the efforts. Was initially my thought on that, but I don't actually know for a fact if there's anything right in that year that made the difference. Right.
Awesome. Okay, let me go to Marv Wayne from the northwest corner of this country. Dr. Wayne.
Yeah, I'm just a country doc. So in any case, first of all, you need to be very much commended, 1 for instituting it and 2 for doing it. So let me think about this, or suggest this, or think about it in a reverse way. We did something a little different. First of all, we've been doing about 18 years of video. We began with the Ranger, for which Glidescope built a box for us to record. We do record all the intubations. They're reviewed at 3 levels, and they're reviewed by the intubator and then attached to the medical record. So that may sound gutsy, but it's really a super educational tool. And medical legally, I think it's sound. Second,
Awesome.
I would say we do the opposite. Our BLS providers all can insert an eye gel. They have about a 93% success rate on cardiac arrest, and we do 100, 110 a year. The advantage there is there's not a lot of time futzing around up with the airway in patients that need everything and anything but an intubation, to be honest with you. We've got about 3,000 videos, just as if you ever want something, we probably got it. In any case, I would suggest the following. 1, you need to download the videos and need to review them with the intubator. Your success rate is so good that maybe it won't add, but maybe it will add. 2, continue what you're doing and doing well. The device is incidental as compared to the success. We use apples and you use Granny Smith, and we use Red Delicious. It doesn't matter. It's what it accomplishes. So again, think about iGel and your BLS providers. While it may take away a few innovations, it speeds the arrest process a lot. Thank you, Peter.
And Mike, before you thank you, Marv. Before you answer Marv's question or comment on it, we have this has been a huge debate, right? We have agencies here locally who have just removed the skill of intubation completely. There's entire states, like in California, which have done pretty much the same thing. And so the reason that I wanted to kind of bring you on is to show the other end of that spectrum. I see Jonathan, Dr. Applebaum from Denver. We have people from all over the country on today, and I'm just curious as to what the other folks on this call would say to this kind of age-old question of should we intubate when you're seeing numbers that are this spectacular. And so, Dr. Lee, come on, you're up next.
Hi, Peter, and thank you very much for the presentation. Very good. I'm looking at this. It looks like you had a 5-year window where, rates were about the same. Basically, 2 comments. My question in looking at that would be, like there's a lot of background noise. My question looking at my comment would be that looks pretty painful, that 5 years, and so I would have to ask, what was the price you paid for putting this in place, number 1, during that 5 years? Number 2 is you made the statement that you allow for 3 attempts. And, there was some discussion, I think, at the Eagles about the question of first attempt, make sure we're not focusing too much on first attempt, et cetera. But it basically had to do with hypoxemia. And so my question now would be, do we really want to wait and go through 3 attempts where, in fact, and of course, Dr. Stephen Katz is a big fan of this, and maybe others, why not just go ahead and do a crike sooner and perhaps save ourselves some hypoxia?
Yeah, that's an excellent point. We've kind of had the debate back and forth whether or not how many do we have the second provider do it. That's an excellent. I kind of had this debate about the years, and we at second attempts and third attempts. You're again, like you said, you're higher risk of hypoxia, and your level of success goes down each time. I'm not really. It's kind of, I guess, kind of tradition is where I don't know exactly what the answer is on where do we stop, or when do you move to crike, when do you move to using it at placing the eye instead. I think right now, given that we have a second, since we have a second medic there, sometimes changing it to the second medic and it seems to be acceptable. I mean, our overall having even just despite the risk of hypoxia, which I guess that's one thing I don't really have measured out, which a little bit issues getting our complete monitor data set to bear with is how many people are actually, and what I love to really focus on forward is how many people is there an episode of hypoxia associated with, is there an episode of hypertension not being addressed, and really laying those out. So that's kind of something we really want to focus on going forward, which I think we teach you with the preparation part piece.
I'm sorry. Yeah, just a follow-up comment. I think that if we were to try to put this in place and we gave ourselves 5 years or 10 years, then I am sure that we can train on it and get to the point that our success rate goes up, however you want to define that. But my concern is, what price am I willing to pay during that time? And particularly, it looks like you have a very large volume, so that's to your advantage. With a smaller volume system, that's a major problem.
Yeah, that's a great comment. Let me bring in Dr. Pepe unless he left already. Let's see, Dr. Pepe, are you there? If not, let me bring in Dr. Applebaum from Denver metro area. Dr. Applebaum, come on in. Welcome.
Hey, thank you so much, and thanks for the invite. Greatly appreciate it. As we're going through within our system trying to implement an RSI program, I'm looking at studies like this and others more in terms of what we can do to maximize the success rate on first pass. I appreciate the iGel, but it's not, I think, in my opinion, as good as intubation, so I'd much rather have the tube. Partnered with this, we're also using a cadaver lab, so people are getting a lot more hands-on experience with tissue. So we're actually seeing a large jump in our creg rate in the meantime while we work on getting RSI on board. So I greatly appreciate you doing the study and bringing it here. So it's incredibly invaluable.
Awesome. Awesome. Thanks, Jonathan. And then last question, just via the text. Larry wants to know about the RSI checklist dosing app that you showed on the screen. Is that something that you've created, or what is that?
Yes, I'm just trying to pull it up here, which I hooked the wrong way. Yeah, so our clinical team basically created this along with one of their supervisors and kind of built it from scratch, ground up. So yeah, so something that I think we get compliance with that for actually people using that. The other, I think, hard to track to make sure it's actually getting used appropriately. We monitor, make sure people are using the shock index dosing, and including further in the app is like using the proper measurements afterwards and getting ideal body weight calculation. But I think that's a great tool to kind of standardize our RSI.
Yeah, checklists need to be used. I completely agree with that. So, all right, well, Mike, thank you so much. I'm going to give you the last word. So you have people on this call who are on one end of the spectrum, and then there you are on the other end of the spectrum. So what would you say to people out there after your data and based on what the comments you've heard today? What's the final word you want to leave us with before we go over to Dr. Pepe?
I mean, I think it's all education program and focusing on this, and I think that's really what got us to where we are throughout. And again, I know kind of you can see the time that it took years to get there, but really this has been a continual focus of our clinical team, really making sure that we're doing everything possible, the right training, focusing on any failed or failed first pass. We're always reviewing any of those cases and seeing what can we do, bringing people information on any case where there's a failed first pass, figure out what was the issue, addressing the issues over time, and really maximizing that success.
I have to find the unmute button. Awesome. Well, that's great words to live by, and we appreciate it. This video will be has been recorded. We'll put it on our YouTube channel, and if everyone sticks around, we'll head over to Dr. Pepe's side. But Mike, thank you so much for joining us, and thanks for contributing to the evidence-based literature. We really appreciate that.
You got it. Thank you very much for having me.
Yeah, you got it.